right, let's transition a little bit over to fixed over fixed. Okay, but this one's going to have a little bit of a twist. It won't be the ultimate of what I'm going to show you tonight. But this was something that we dabbled with the end of last year, early this year, and that is using some scan bodies in order to digitize the position of the multi-unit abutments. Kind of a neat approach, but I'll get to that. So this is another case. This patient was actually on removable, but patient wanted to test drive the prosthesis. They wanted to see the bite, the smile, the tooth position, the feel of it. So this is a little bit more than most are going to do. But doctor put multi-unit abutments in, did a digital workflow in order to make prosthetics, just some kind of down and dirty prosthetics to get tooth position, smile, lip support, basically get the patient to sign off on this big expensive case with a test drive. Right? And so at this point, there's a couple different ways to go for records. The patient's stable, got a good bite, and this was early on. And so what we did was we decided that doctor would just scan the upper lower because they've been equilibrated. So scan upper lower, include some palatal tissue, which is, we'll get to that in a little bit, but that's really important. Get some palatal tissue. He put some scan bodies on the multi-unit abutments and digitized the patient. It's pretty creative. And then, and the next part will be kind of first time I've ever seen it. Dual scan here on the right. And what we did was we planned GuidedSMILE. Kind of fun pictures here through the RealGuide software, again, of the limited real estate, and you can see why we want to have structure here when we do these cases. But we made pin guides that are made to fit the actual scan bodies. And this one really got us thinking, you know, what the possibilities are, because it's kind of silly to put scan bodies in the mouth and put a prosthesis on it. Or a pin guide, but that's what we did. And doctor went through the whole process, pinned them, very stable. Obviously there's flare there, so we had to block it out. He even had access from the top to screw him in while he was in the mouth because of the trajectories was a little tricky for draw. But that pin guide nailed the fixation base perfectly, put it exactly where it's supposed to be. And we knew at that point that was going to be the way there was something here, right? Something here that would give us the precision. All right, leave them out behind. Conventional pickup. Most of these cases, maybe the first 60 or 70 cases, were full stackable GuidedSMILE prosthetics delivered in surgery, delivered with the case. All right, looking good. Upper, same thing. Nice position. Again, the pin guide was resting on the scan bodies. Implants come out. Implants go in. Leave them out behind for stability. And then just kind of showing off the precision of the whole thing. All right, so there you go. And then finish up the case. So a patient went from removable to fixed to ultimately to a long-term temp there. And you can see the engineering of that plan, the implants, the pterygoids. Now he was placing pterygoids guided. You know, you saw that here in the, you can see on the back right, top back right, fully guided case to get these pterygoids in the right place. Really nice case. All right. A little recap, just a few seconds on this. This was a recap. So I'm kind of moving from left to right, where we did traditional dual scan, and then we started scanning the prosthetics. Then we started scanning the tissue and the locator abutments in the mouth, and we would use that scan of the mouth, and we would basically invert it and attach it to the denture dual scan for precision. And we just kept dialing it in. And then recently, I invented these arch bridges for locators. You can see it in the bottom right. You just click those onto your locators, and your locator position is perfectly digitized. So we're not totally rolling that out yet, but you can imagine the precision with a new style Grammetry scan body on locators, and what that will mean. So let's go through Jay. Hers is a little bit of a combination of what we've been talking about. Upper is fixed, lower is natural teeth. She has been in a excuse me, she's been in a fixed hybrid for many years. Uh, this is just acrylic, repaired, super glued. A lot of love went into this case, holding it all together until it was really just time to restore. Right, so the upper is going to be a revision, the lower is just going to be a full arch case. So just real quickly with the records on this were obviously the photos. Use our checklist for the photos. Very important to pick the exact right ones because we use the photos for a lot of things. Bite, smile line, transition zones, vertical, smile, like all kinds of things. So we like to have the photographs. These are not the photographs. These are some of them. Intraoral scans, upper, lower bite. And again, I don't show it here, but make sure you scan the palate on these cases. Otherwise, you don't have any references. You got to scan the palate. And then on the bottom right, you'll see a 360 scan of the prosthesis. Okay. And then scan the prosthesis in the mouth because it's all acrylic. Doesn't have a bunch of metal. Alrighty. And then we work up the case. Right? Plan everything, plan the bone reduction, the pins, the implants, everything. And Jay's case was one of the very early ones that we did. So I'm moving them around a little bit here, but mostly for educational purposes because as you'll see on that image on the right, look how far labial our fixation base is. Very far. And that puts a lot of stress on the pins. This case is a pterygoid guided case. We don't want flex. We don't want movement or wobble, not flex, but wobble in the fixation base. But we don't have any choice because the patient's already wearing a prosthesis. And you can see the draw on the left image, how far labial we have to get beyond the teeth. Now, I know that there are guides out there that you put on the bone and then you come in with a fixating device, but there's just too much undercut for that. You have to have a bone reduction guide that's not engaging the actual bone, but is pin supported, and it's just too far labial. So this was one of the reasons that forced us into thinking another way to make pin guides. Very important, right? That whole, obviously the pinning process. Now, doctor got through it. Did get some stability. Obviously, it's being inserted on the patient's existing teeth. So there's lots of stability there. But the real issue is, are you going to maintain stability through the whole surgery with 4 pins like that in the anterior? And that is why you leave them out behind, right? Get the first implants in, leave them out, secure it, and then you can address the pterygoids. All right, better situation. Now, this was early on where we first started doing some in-office printing. So just kind of worked it up just to get the case, get Jay out the door, home recovering, and then come back later and do some pink. So a few weeks later, number 10 was lost, and we wanted to replace it. We don't want to leave that long span with only number 11 there supporting it, right? So now we're at revision number 2 for the same patient in, a short amount of time. But we know what to do here now, right? Because we've been doing this. This is fast forwarding from her first surgery, but we know what to do. And that is take a CT scan. That is, patient actually went back in a denture temporarily. So scan the denture 360, perform a dual scan, and you'll think, oh boy, these are a lot of records, right? But do the dual scan, in this case, scan the abutments with the intraoral scanner. Now we can easily stack everything together, right? Palate tissue. And then, isn't that beautiful? On the right-hand side, micron mapper. So I had a grammetry and now a photogrammetry protocol. So in the time we've been working together, Doctor bought a micron mapper. Scan those multi-unit abutments. Now we are dialed in. We stack the study model, plan the implant, right? And something else to consider, and this is something I would have mentioned, I should have mentioned earlier, is that the patients that you're seeing, all these patients, they are dental savvy. They have been through it for years and years. They have a high dental intellect and they're in a bad situation, right? So one of the reasons Dr. Castedo is doing so many of these cases successfully, getting patients to say yes, is because these patients are on the fence about what to do. More money, more surgery, more risk, and his whole stance to them is it's going to be guided. We're going to engineer it. I'm going to put that number 10 in there exactly as you see it on that screen. That's where it's going. Not going anywhere else. And I'm going to show you where the bone is, and I'm going to make sure that you have confidence that I'm going to deliver this case as I promised. How nice is that for a high dental intellect patient? They love hearing it. They say yes because of the precision of this. Now look at what we did here. Yes, over-engineered, right? But how much work was it really? There's no sleeves, right? It was just a micron mapper scan and some other normal guided surgery scans. We used the best screw in the world, in case Dr. D is listening. Great screw, vortex screw, cinches down, tightens it up. We can use any screw, don't get me wrong. Des, Rosen, Seg screw, any of them. We can use any of them. Screw it in, wait a couple minutes, screw in a little bit more, some tissue pressure, and then once it's down, you are going to be drilling in the right place. And again, these are all Nobel BioCare implants. This is their whole Nobel system, the voucher system. And so their guided kit is going to intimately put that implant in the right place. All right. Expose it, screw it down. You don't need all the screws. Put the implant in. Nailed it. Right. And then on the day of surgery, if you want, you already have a micron mapper. You can put them all in or some of them in and just pick up number 10. It's the same with any photogrammetry system. Pick up the one missing implant, make another prosthesis, and then go to a long-term temp. How beautiful is that? We went from revision 1, revision 2, and now patient Jay is happy for the first time in many years and went through it confidently. And let me tell you, Jay has a very high dental intellect. I don't want to give any details of why. Very, very high. And that is why she was able to deal with this patched up prosthesis for so long, because she knows. She knows what she's in store for, and she wanted the vision of the doctor to get her all the way through the end. All right, so from black hearts to pink hearts, Jay did it. Nice job. Nice job. So screw down was the way to go, and screw down is the way to go for a lot of these cases.